Okay, thank you. Welcome back. Welcome back, all the people at home. As you may hear, that I am switching from Dutch to English. This is the third block of the honorary retirement webinar because of my retirement in the Ministry of Defense. Here at the Dutch Veterans Institute, where I'm currently standing, we've had two blocks, block number 1, block number 2, and this is the third block. And I just overcame some of my nervousness and emotional because of the decoration that I now am able to carry, that I'm extremely humble and very pleased to have received. This is a very special block, as the other ones were. This is a block where I have the pleasure to invite colleagues and friends from all over the world. And we will be listening into a couple of colleagues that will share with us in the first half hour some of their insights in PTSD clinical research. And I will call out for them to join me in the Zoom session. But before doing so, let me try to encourage you to take out your phone again, like you've done in the beginning, and go to www.menti.com. And just a couple of questions that I'd like to entertain with you. And the first question that I'd like to ask you is, the code you need to type in is 5714804. If you cannot see it in the audience, the people at home is probably easier because they're able to look at this from their computer. So the code is 5714804. And a couple of questions to just exercise your thinking. And the question is, what stands out in PTSD research in the first decade? Let's say 1980 through 1990. What comes into your mind? You can do it in Dutch, you can do it in English, and this is going to be a word cloud. As many people as are signed up, we see a glucocorticoid receptor. It's in the middle, but to get it on the map, start aandacht PTSD. Exposure, I see some more. Definition, Vietnam, FKBB5, SSRI, definition. It may be difficult because it's a long time since. It's about, 40 years since. The first decade when PTSD was on the map, after it was introduced, DSM-3, the glucocorticoid receptor is still number 1, which actually that predates its finding, but okay. Herbelevingen. Okay, we got 26, okay. The beginning, right? Erkenning, understanding, intrusions. Thank you for filling this out, because the next one is in line with the first one. And let's go to the next one. The next one is, what stands out in PTSD research in 1990 to 2000? So you can give the same answer. You can give a different one, like, if I think back in 1990, 2000, something else came up. What was introduced in that decade? Let's see what comes up into your mind. Therapy options, pharmacology, normaliseren, EMDR. Okay, let's see if EMDR pops up in more people. If I mention it, you may drop EMDR, and it's going to be at the center. Prevention, invention of PTSD, biological, medication, glucocorticoid receptor, building knowledge base, Prismo, keen, nice. All right, we got 23 people participating on this one already. Great that you're participating. EMDR still is in the middle, and that's great that you're all recognizing EMDR as something that really came up 1990, 2000. We got 2 more. So the next one, please, is what stands out in PTSD research from 2000 to 2010? Anything that came up, anything that wasn't there in the first couple of decades, what stands out? EMDR, neurobiology, Prismo again. Vermetten. Biological aspects, pharmaceutical options, preventie, cultural criticism, psychotherapy, EMDR is still in the middle because that was sort of the hype of EMDR that was starting on the rise. More EMDR was recognized as an intervention that we desperately needed at that time. Cease EMDR stands out compared to the others in the work cloud around it. Thank you for being so swift in participating in this. So, and the fourth one, and you can already anticipate what the fourth one is. If you can have the next one, please. If you're still thinking about the last one, let it go and just focus on the next one, which is 2010-2020, which is the last decade that we sort of left. Okay, well, MDMA is really at the center. 3MDR, biofeedback, tech innovation, psychedelic research. Vermetten again, tech innovation. Maatschappelijke aandacht, afronding van mijn PhD. Reflection, psychedelics, psychedelic research. Project Eric. Thank you for being so swift. All right, these were 4 questions. Just the technology. Is there a 5th question, or are we pausing for these 4 questions? All right. So thank you. That sort of sets the stage actually for calling out to 4 colleagues. And if I may see if they're all on board to the technology. And I'd like to invite Professor Rachel Yehuda from New York, Mount Sinai, Professor Sandy McFarlane from Adelaide, University of Adelaide in Australia, Robert Dorsano in Washington, United States, and my dear friend Rakesh Jetley, a retired colonel, Canadian Armed Forces, to join me for this session for the first half hour. And as we're all aware, it is very, very, very late in Adelaide, in Australia, and it is early in the morning in Canada and in the United States. Good morning, and it is so great to see you guys from my angle here. Sandy, happy to see you that you're still awake in this middle of the night in Adelaide. Good to hear you. Can you raise your voice so that people can hear you?
My alarm woke me up, Eric. It's fine.
All right, good to see you. And Bob, good to see you always.
Always, Eric. Congratulations.
Thank you so much. And Rachel, also good to see you.
Hi, Eric and everybody. Great to be here.
And hey, Rakesh, good to see you too.
Hey, buddy, always great. Wish
right.
to have been there in person. Bit of a cold. A lot of that's going around lately, I think, guys.
I am so grateful for you to be with us here for this session. And if you may have been with this session in the beginning, I was just awarded with a medal by our Ministry of Defense, and that humbled me. And I'm deeply with great gratitude for having been able to receive that. So that's why maybe a little bit of nervousness that's still in my voice, but I'll get over that. What I'd like to do with you and in this session is, and we have exercised this before, and you may not see us, but there's an audience of about 30 people here in the room. Some are uniformed, some are civilian, dear friends and colleagues. And you are the experts that have been very important in this field that we have just been discussing. And what I'd like to do in the next sort of 25 or so minutes is to ask you we've been just looking at the history in the past of the past 4 decades. What is, I'm going to make it really popular, what is hot and sizzling in clinical research in PTSD? Or what have you learned in PTSD that could be a lead for the next decade to go for? And I know that you're active, you've been my role models in this field. And I'd like to call first, because you're the latest in the evening, Sandy, to start with this session, to give a couple of insights on where do you feel that this field is taking a new lead or could benefit from an insight that could came from your wisdom. Can I give you the floor first, Sandy, to give us some ideas on where this might be going?
Well, first of all, Eric, it's wonderful to be here on such an auspicious occasion, and congratulations for everything you've done, the contributions that you've made in the field. Look, it's a very interesting sort of issue to contemplate, because I think one of the challenges is that I think the field has come a very long way in over the decades that you've just asked us to reflect on. And I think the challenge is whether the field has become somewhat sort of conventional and stuck, and really what is innovation going to bring? And I think one of the first things is that the contribution that you've made is that of longitudinal research in the field, and I think we need to, have a much more nuanced view as to the different causes of post-traumatic stress disorder and traumatic reactions, and really the subtypes of this disorder. I think we've had a very I think we haven't really understood and adapted to the diversity of this condition, and the differences in the neurobiology, etc. And I think the second challenge that we really face is the whole problem of treatment resistance and treatment non-response. I think the psychedelics is a major step forward in that domain, but I think the whole issue of treatment outcomes has been politicized. I think it's been hijacked by certain schools of psychotherapy who've perhaps overstated their effectiveness. And I think that's not been to the service of anybody. So I think there's a huge need for innovation. And I think particularly to understand the patients who don't respond to frontline treatments, and how we might better engage and treat those people, and the whole sort of biological drivers of this condition that we understand a great deal, but I think we really do very little to directly target in our treatments.
So what would you prioritize if you list those 3-4 options? What would be the first on your list?
Well, look, I think one of the first things that we should be doing is in clinical settings. We should be, I think, we should come up with some international protocols about a whole set of baseline measures that we examine in patients, and really be much more engaged in trying to predict treatment response or treatment non-response. Because I think really what we lack is any sort of decision-making hierarchy that takes us into effective decision-making about predicting treatment response and how we could better target and optimize patient outcomes.
Thanks, Sandy, for those wise words. Treatment response and predicting treatment response would be top of your list. I'll go around the table, and some of the audiences may not. Sandy McFarlane, if you go to the landing page, then you can look all the biographies of all these presenters. I'm going to call them not all in length because that would be taking a little away too much of the time. But these are all experts in this field, and you may have already seen that. And the next one I'd like to call, and we'll start to engage and reflect on each other's. Maybe Bob Bersano, could you give your scoop on the question that I raised to Sandy? What do you feel we need to learn from most, or what we desire to get more knowledge on or invest in?
Well, I appreciate the opportunity to be here, Eric, again, with you and with my other colleagues and with the audience. It's always a pleasure. And being here, there are two things that come to the forefront, and having the opportunity to have spoken second after my colleague Sandy, I got to jot down a couple things. So think fast is usually the rule around Eric. But first off, Eric, I want to salute you. And also what I think has become so important has been the global issues of PTSD. You know, PTSD as a diagnosis in many ways grew up from the United States and the Vietnam War and expanded out. It clearly now has a global footprint, global attention, and is established as a disease relevant to the world. From that perspective, I would also, it's difficult to not recognize that we remain in a COVID pandemic. the pandemic, how it will unfold, whether it will go away. Is there a new variant around the corner? In the United States, although the rates are going down of cases, the critical issues are how it has impacted infrastructure, in particular hospitals, but not only hospitals. Our hospitals beds remain very full. Now, why is that related to PTSD? Well, certainly there is PTSD associated with it, but I would say there's a much broader context, which is that of the DSM-5. One of the stellar accomplishments in the DSM is not the changes in the diagnosis of PTSD, but the establishment of the chapter in which PTSD now sits. You will recall that there's now a chapter, trauma and stress-related disorders. Why is that important? Because it says there are more, and there are more yet to come as our understanding expands. PTSD is not the only trauma response. We know that already. We know panic disorder increases. We know depression increases. We know substance use goes up following trauma exposure. As we are better able to link what I like to call event-related disorders, something happens and a response follows, we will expand our understanding of trauma-related disorders, and that chapter will grow. So that PTSD is a bit of the tail of the rabbit. As we see the rabbit up ahead, we notice the tail, but there's much more as we follow that rabbit. Thirdly, I would say, following on the global issue and the DSM and the COVID, is the importance in public health, that the issues of a public health perspective on PTSD, not just individual treatment. What are its rates in various nations? How does it affect loss of economies, loss of ability to sustain families? How do rates vary in different populations, and why is that true? And then finally, I would mention two other things which ricochet into a different direction. I absolutely agree with Sandy's comments on the importance of longitudinal studies. If one also takes that in another direction, the microstructure of understanding what goes on in PTSD using EMA type studies, in which one asks, how do symptoms vary in a week? How do symptoms vary in a day? More in the morning, more in the afternoon, more on weekends, more during the week. It offers us a window on brain activity, a window on life events, and potentially windows on when we should better target treatments. Perhaps our treatments should be targeted for operations on weekends, or maybe not on weekends. Maybe weekends should be holidays, because in fact, the primary microstructure of when there are symptoms, not just the symptoms of PTSD, but those that accompany it as well, such as sleep disturbance, we may better be able to time our treatments. And then lastly, in a similar vein and following up on Sandy's comments, precision medicine. Precision medicine is the phrase everywhere. Perhaps it is better stated as personal medicine. So we better get the right treatment to the right person at the right time. As you know, Eric, part of our work and working in large data sets has been to try and develop such tools. We aren't quite there yet, but we're getting there. Tools that become decision aids for clinicians. We know that, for example, we can, in principle, Ron Kessler, a colleague working with us in the Army STARS study, that we can identify following psychiatric discharge 4 out of 100 people that'll be dead in the next year. Well, we have to treat 100 people to protect those 4. And what treatments do we have in psychiatry and psychology that allows us to do that in economics and at scale, and that doesn't have negative side effects? It may seem strange, but it is what we do in medicine all the time. We give statins to 100 people in order to help 7.5. The other 92.5 people, it didn't make any difference at all as to whether or not they had taken that statin. can, in fact, our tools for PTSD reach that level as well? A great question. Thanks for the opportunity to comment on it, Eric.
Thank you for those words. Wonderful. 1, 2, 3, 4, A and B. I jotted them down, Bob. Thank you. Same to you, Rachel. What is your take? Please go ahead.
Well, hi, Eric, and thanks for inviting me to come to this wonderful event. And I want to just add my congratulations and my kudos to you for an amazing military career. And the bright spot here is that you're asking about the future, meaning that you're still going to continue to be very active, which is just wonderful because you've made so many contributions. And it has truly been a delight and an honor to be your colleague. And I really think this should be about you. But you told me specifically that you don't want it to be about you, but I think we're all here because of you. And I just want to make sure that we acknowledge that. You know, I've been thinking about your question about where the field should go. And it's such a good question, really. I think since 1980, when PTSD first became a diagnosis, we've been creating knowledge at a very rapid pace. Really good knowledge, I think, by many people who are on this webinar. And we know a lot more about trauma than we ever thought we could. In the beginning, the diagnosis was controversial because we couldn't wrap our heads around some of the big mysteries about, you know, why the effects of a single event could be so enduring and transformative, and what accounts for individual differences. And I think we've largely answered some of those questions. But I will agree here with Sandy that we just have not solved the problem of how to treat PTSD. We haven't solved the problem of understanding why people respond differently to different treatments. We just don't have a sense of really why our current models of clinical care have failed us. And I think we could keep going and try to find new treatments. Of course, psychedelics is one avenue that I know you're interested in, as am I. But I think the most important thing for us to be doing now is simply reflecting about what the information that we've gathered to date has really taught us. Whether there really is a connection between all the biologic data we're collecting, the epigenetic data, the personalized medicine, whether and how that information really does lead to treatment. And then I think we also want to think about how recovery from trauma is really achieved, and what is the role of psychiatry or of mental health in helping people kind of reach the other side. And, you know, as both Sandy and Bob were talking, I just had this image that I think in a way our foot has been very heavy on the pedal, you know, to really, in the sense of we see a trauma survivor with PTSD and we think, what can we do? What can we administer? What kind of treatment can we provide? And maybe we need to take a role that's more like a midwife than, you know, a surgeon performing a C-section. Maybe healing is a process that requires elements that we have not yet considered because they've been too difficult to study. So maybe what we need is a review of the information that we've collected, what is most useful and what is perhaps less useful in understanding the healing process and how people really take the traumatic events that they've experienced and really move over to the other side of that and learn to, despite or because of what has happened to them, go forward in a different and positive and meaningful way.
Thank you for sharing these thoughts, and for the audience, you may know that these are people like Rachel Yuda, who has introduced me to this field, writing books on the psychobiology of PTSD that goes back decades, and really the openness, like what have we learned and where are we going? And then to hear you say we need to reflect. And I like the analogy on midwives, and we need a review of how far have we become. Thank you for sharing that. And last year, I may go to at this moment for now, with the four of you, is Rakesh. Thanks for being here, my friend. Maybe you share the audience, like what pissed you off in the beginning when I became a colonel.
Oh, geez, Eric, I've got a bit of a sore throat. I apologize, but I'm either to blame or get the credit for Eric joining the military. So way back in the day, I said, if you really want to do research in the military, I was a major at the time, you need to just join because you're always been outside or otherwise. So I remember driving home in Halifax once, he called me and he goes, hey, buddy, I joined. I go, that's great. He goes, and they made me a colonel right away. So I said, oh, that's great. That doesn't bother me at all. Then I hung up. Then I called him back a couple of minutes later. I go, yeah, it does fucking bother me. But anyway, buddy, it's been a long time since then. We will, excuse me, we will celebrate this properly with a scotch and a cigar when we can meet in person.
We still. Rakesh, he retired just before me.
I retired this year, exactly.
After 30 so much, 35, 6?
31 years or so.
31 years of service in the Canadian Armed Forces.
Yeah, but who's counting? But as Bob said, it's hard to follow Sandy, and of course, it's hard to follow all three of these esteemed colleagues. So, I mean, of course, I don't disagree with anything. But for me, what's interesting when you're asked to reflect is, as a doc that's been a physician for about 30 years, is PTSD in my training began as an anxiety disorder. You know, and as a military, flight surgeon, physician, I just kind of remember that somehow this doesn't seem to be the same anxiety as agoraphobia, as a phobia. There seems to be something different. And in my post-grad training, PTSD was 10 minutes of the lectures of anxiety disorders. A few years later, when I started to give the lectures, PTSD was 2 half days for the residents. So it changed quite a lot. But I think more importantly for us as military physicians, the war came in. And I remember Sandy for years and years would show all that history of, the battlefields and cannonballs. And yes, Sandy, I did pay attention to all those lectures that I've the privilege to stand. And I think the IEDs, the explosions, it took us back to World War I, the idea of shell shock, the idea of the whole body disease. And when you have sort of the criterion A event and the grief and loss, and have your body sort of blown into bits, that all sort of became, so it brought us back to this idea of the whole body. From a simple anxiety disorder treated with exposure, it became this complicated physical illness with neurobiology, biology, inflammatory markers, whatever we're going to talk about, and then mixed with the grief and the loss that we often see as well. So I think, to Bob's point, that's why we have trauma disorders now. We don't have just this simple, this was really scary, now I've got an anxiety against it. So I think that's really important. Couldn't agree more with the idea of technology, data analytics, predictive analytics, whatever we're going to call it, because again, we don't know how the patients we treated last month are doing, never mind 10 years ago. So we need to sort of get better at that. And the last point, Rachel and I were lucky enough to be in New York a couple of months ago. And one of the things that I've realized since leaving the military, and you're going to see that as well, is that no matter how good our treatments are, typically, whether it's through charities, whether it's through academia or government, military people and veterans get the best healthcare. And I think we need to think about the health equity piece as well, because now you're going to find out, you're going to get calls from doctors whose people are refugees from horrible places, have childhood things, and there's very little available for them. So as we develop these treatments, as we get better treatments, more efficient treatments, it'll kind of help us to make sure the people that really need the treatment get it, as opposed to the people that are lucky enough to have veteran next to their name or colonel next to their name, that kind of thing. So I think the health equity piece is the other piece that I'm hoping we get as we move forward, because trauma is not unique to military and veterans. And I think I'll stop there, Eric.
Well, thanks for these words. And what I'd like to do now is go back to the first one that you mentioned, Sandy, but do two things. And maybe you can reflect on the question that I'm often struggling with. What is treatment resistance? And how do we get about that? What is it? And how do we, what is it? Is it our problem or is it the patient's problem? What is treatment resistance? As we're doing that, we're going to open this to the world, and you may see more screens popping up. And as you reflect, maybe I can start to invite, and it's going to be very populated on the screen now. So don't be scared. I'm okay. We're going to call on, if that's okay with the technicians, we're going to call on Gary Wynn. Gary Wynn is a retired colonel, and he's now residing in New Zealand, and it's very late now in New Zealand. If we can ask him to join us on the screen. We're also, hey, there's Gary. Good to see you, man. It's late in the evening. It's midnight in New Zealand.
It's 4 o'clock in the morning now.
Oh man, it's brutal. I so much appreciate that you're here with us.
Yeah,
And you're still
absolutely.
wearing your USU shirt or fleece.
I am representing.
Good to have you. I'm going to call on others too, and then I'm going to reach back to you, Gary. Gary moved from Washington about a year ago to New Zealand, and he's now in, it's not Charlottesville, or where are you residing?
I'm in Wellington.
Wellington. Okay. Okay, we'll get back to you. I'm great that you're here with us for a few minutes, or are you sort of dozing off? I'm
I
going to
have
call you
coffee.
first.
I'll be with you the whole time.
Yeah. We're going to call on a colonel in the Japanese self-defense, Japanese Ministry of Self-Defense, and it's Masanori Nagamine. If the technicians can identify Masanori Nagamine, then we're going to call to see if Masa is going to join us. Masa, are you with us? Hey, that's Masa. Arigato gozaimasu.
Hi.
The only Japanese that I can speak, which is hi, how are you doing? I think. Masa, good to see you.
Yeah, good to see you, Eric.
It's late in the evening there for you as well.
Yes, it's midnight in Tokyo.
It's midnight in Tokyo. It's great to see you. This is really a beautiful global connection because we're reaching out to the world. And you're far in the east. Stay with us for a few minutes.
Yes.
All right, Masa. We're going to also see if, I don't know if technology is able to call on, are all the people there? Let's see. We'll see. We still got everybody who's able. Simon Wesley, did you recognize Simon Wesley? So Rick, these are the people that I've flown to. So this is the investment of my trips over the world. Hey,
Hi,
there's
Eric.
Simon.
Yeah, hi Eric. Congratulations.
Sir Simon Wesley. I need to say always when I call on you, I say sir, and then you look over your shoulder. Who's calling for me?
I do. So if I join the Dutch Army, can I become a colonel? Sorry, that was my wife just intervening there to wish you all the best for your retirement as well.
All right. What did you say? What did you ask, Simon?
Now, I just said, if I join the Dutch Army, can I become a colonel, please?
Oh, there's a couple of generals here that could answer
Oh,
that
good.
question.
Okay.
Yeah,
Put them in
sign up.
touch with me.
I did it in 6 weeks, Simon. So, Joseph Zohar from Israel. Josie, are you here? Let's see if Joseph Zohar is in Tel Aviv, in Israel. Oh, good to see you, Yossi. Hi, wonderful. How are you doing, Josie?
Great.
You're 1 hour ahead of us.
To be here. Congratulations on this excellent event.
Thank you. And the beauty of this, all these people know each other. They're not strangers to each other. They know each other from conferences, from meetings, and we've been hanging out in Odessa and other places in the world. The next one is Suzette Bremel Phillips. Are you with us, Suzette? From Adelaide, from Alberta in Canada. Hello, Suzette. Good morning.
Hi. Good morning and congratulations. A wonderful event. Great to see everyone and wonderful to participate in this with you.
Wonderful. And congratulations on the grant that you just sent in last night.
Thank you. We'll see how it unfolds.
They've just sent in a cannabis grant in Canadian, and Suzette is the director of the Highmark Institute in Alberta. Stay with us for a few minutes if you can, Suzette.
Absolutely.
Thanks. And we've got Ulrike Schmidt from Bonn in Germany. Ulrike, are you there? Hello, Uli. Ulrike is a psychiatrist at Bonn University, and she was at the Max Planck Institute where we met several years ago. Good to hear you. Good to hear from you.
Hello, can you hear me? I have a bit of
Yes.
technical problems. Hello, so thank you for the invitation and congratulations for the honors you received today, and I'm happy to be here. Thank you.
Thank you. Thank you. Great to see you, Uli. And next is Guga, Georgi Sikarolidze. Georgia or Georgi or Guga Sikarolidze. There you are from Tbilisi in Georgia.
Hello to everyone. It's
see you.
wonderful to be here, and my congratulations. So nice event, Eric.
Wonderful, wonderful to see you and the smile on your face. Georgia is a wonderful country. 3.5 million people live there. They're always under this pressure from Georgia, from the Russia in the north. They have their own language, their own culture. It's a beautiful language to speak, which I cannot speak any of. But good to be with us. Good to see you, Guga.
Thank you, Eric.
And another one is from a special country that's in the news a lot. It's Irina Frankova. Irina, are you with us?
Yes.
Hello, Irina. Irina
Hi.
is currently in Kiev in Ukraine.
Yeah,
Good to
Eric,
see you with
thank
us.
Yeah, great to be here, and I'm so happy to see so many familiar faces, and I hope we will see each other in person very soon.
Look forward to that, Irina. And thank you for being with us. I don't have the next one with us. No, that's Rick Doblin. He had a procedure and he sent in a video, so he may have to send his regrets. But the next, and he may join us later, Torsten Passi. I did see him earlier. Torsten, are you with us from Hamburg?
No, it's
Berlin.
no, it's Hanover.
Oh, sorry, Hanover. You see, okay.
But it's in the same
Good.
geographical area. You could say it's in the middle of Germany. And so my background, just to mention that, because I know nobody, nobody knows me, maybe. So my background is I'm a psychiatrist, and I've worked quite a bit with severely traumatized patients, especially so-called heroin-dependent patients. And I've also specialized in the use of psychedelics in psychotherapy since 35 years. So and I'm quite involved with MDMA, wrote books about it, and so on. Yeah.
Great that you're with
great
us.
to be here, and my honors to you as right now the kind of European leader in psychedelic therapy, so to say.
Great. And if I see, when you're speaking, I see that Rick Doblin has just joined us. Hello, Rick. Hello, good to see you. You're in the hospital, or are you?
Yeah, I'm in the hospital, but I'm fine. And so I'm really glad to be able to join.
Wonderful to see you too.
Yeah.
Rick Doblin is the director of MAPS, is the Multidisciplinary Association for Psychedelic Drug Studies. Great that you can hang out here with us for a few minutes.
Yeah, well, for the whole rest of the hour.
All right. And now maybe for some others that we also try to connect. I don't know if any others that the screens, are they there? Can I call? Andy Greenshaw is with us. Andy Greenshaw is a colleague of Suzette Bremo-Phillips, also at the University of Alberta in Edmonton. Andy, good morning.
Hi, Eric. How nice to see everybody. Great to see you. Thank you for the invitation. Congratulations. What a great day. It is a remarkable celebration of a fantastic achievement. Your connections with such a wonderful network make really a huge difference and continue to. And we're looking forward to this next phase of your career where you take all of the great stuff you've done in your military engagement and move it out into the public domain. And one thing I'd like to really commend you on is something I keep coming back to, your recent paper where you had dinner with some patients and their spouses, and you did an analysis of what it really meant for them in terms of their lived experience. That is an area we really need to move into to get a fuller picture. So thank you for your leadership and your friendship. Look forward to seeing you again soon.
Thank you, Andy, for saying those words. Thank you. We still have some more to invite. Okay. Well, let's see if they're there, because we asked if David Spiegel could join us, and David Spiegel may join us, and Carl Castro may join us. Aha, because wow. And I don't know if Ruth Lanius is there, but she did call up, she signed up. And they are. Let's welcome them. You know, this is beautiful to see all these people on the screen. This is a global connection. We're all into this world of PTSD research, clinical research. And here we are. Ruth, good to see you on this screen.
Great to see you.
Are you now in Newfoundland or are you in London?
I'm in Newfoundland, and it's wonderful to be here and to see everyone. And many congratulations. Thank you for your great contributions, your friendship. It's been a real honor to know you.
Likewise, Ruth. And maybe David Spiegel, if he signed up. Can you recognize David? All right.
I'm here.
Oh, wonderful. David, my dear
Eric.
friend from the 1991 Stanford.
Yes, that's right. It's
good morning. Good morning, Stanford. We don't see you yet. Let's pop up the screen to see you on video. There you are. Hey, David. Good to see you.
Eric,
good morning.
Congratulations. Thank you. Great
Wonderful
to see you. And it's sobering for me to see one of my best trainees retiring. Doesn't make me feel any younger, I can assure you. I particularly admire what you've done to make the invisible visible, to help bring to the military and bring to the world a deeper understanding of what happens in the brain, about how we regulate and dysregulate emotion in the face of trauma, and also what the lasting damage and problems are that come from traumatic experience, and making it visible to people. It's a little bit like a gram stain with bacteria, that it helps you see things that are in front of you, but you don't recognize. And I think you have done a great deal. And in particular, I want to mention dissociation, which is a way in which people hide from themselves the experiences that they've been through and what it means. So helping us understand what goes on in the brain and how people can manage it is something you have contributed to a great deal. And it's always been a real pleasure to see you and to see the wonderful work you're doing, to hear about you from an airport being bombarded in Afghanistan or somewhere else around the world. You're really a remarkable guy, and I deeply appreciate all the work you've done.
I appreciate those words. David Spiegel was the one that mentored me into neuroscience when I went to Stanford in 1991. I was trained by David and his father, Herbert Spiegel, on the use of hypnosis in psychiatry. And you've been a role model for me throughout these years, David.
Thank you.
And we saw Søren Andersen from Denmark also popping up. Søren, good to see you also here. Søren Andersen is a psychologist, a clinical psychologist in the Veterans Institute in, I don't know whether it's Aarhus or Søren, can you hear us?
I can. Apologies for the delay. Copenhagen.
Copenhagen. And you were just with us for the defense of Debbie Knotner Johnson, who is also here in the audience for her PhD defense. Good to see you too, Søren.
Good to see
you. There you
too.
are. Ah, great that you're joining us.
Thank you.
So the next one may be that are two people that I think I could call for, but I'm not sure. This is a test. If Bessel van der Kolk is with us. All right, that's Bessel van der Kolk. He's in Massachusetts, but I don't know exactly where he's located, but I think is Bessel there? There's Bessel. Hey, good to see you. I think Bessel, you started in the Netherlands, being born here in the Netherlands, and everybody knows you because of the brilliant book that you have published. I think your name. How are you today? And good to see you.
Great today.
It's wonderful that you could join in.
It's great to hear about Jan Bastiaans, whose secretary I was back in 1966. And Bastiaans actually helped me to become a psychiatrist, because on the first day I worked for him, a paralyzed woman was carried into his office and she walked out. And I thought, boy, psychiatrists can make people walk. I'm going to become a psychiatrist, just like Jan Bastiaans. And it's also a delight to be here, because this collection of people really shows how this is a communal enterprise, and all of us have been very close to each other, struggling with all the basic questions that Bob Ursano and others talk about. And it has been an exciting journey for all of us, and you have been a very important part of that journey.
Thank you for saying that, Bessel. But you've also been a role model for many of us, where you started to write the 1994 people, the body keeps the score, that opened up a roadmap for so much research. And that metaphor is so helpful for many people, both on the clinical side and also on the patient side. How many languages has the book been translated now to?
40.
40. Just
so
that
when
book
Bob
has been
talks about the global reach.
Exactly.
Yeah.
That book has been on the New York Times bestseller list, nonfiction, for how many weeks now? Number one?
170 weeks.
Let that sink in. That is like, how many years is that? That's not weeks, that's years.
That's, well over 3 years.
Well over 3 years. Great to have you with us, with this group of colleagues. And then I'm not looking at the technology. This screen it's a beautiful screen. It touches my heart to see all of you. Let's see if Carl Castro has joined us. And then I think we should stop, because then the screen is full. And then we start to entertain actually some of the questions that probably may also puzzle us, but may also incentivize us. And I reached out to the question to Sandy, and they've had some time to reflect. The question is, what is treatment resistance in PTSD? How do we get about that? And let's first try to, we can shout, and then it's going to be a massive disorderly conversation, but let me try to moderate, and let me try to call out for Sandy, who first was the one that mentioned the word treatment resistance. Sandy, could you reflect on that word? What is it helpful, or is it puzzling, or what does it say? How is it informative for our community?
Well, I think why it's informative, Eric, is because I think that one of the difficulties I think about psychiatry and psychology is you have therapeutic schools who are a bit like a beauty pageant, who are sort of trying to compete with each other to sell their wares. And I think one of the things that the schools of therapy or methods of treatment are very good at doing is talking about what they can do, not about what they can't do. And, look, there are some very good definitions of treatment resistance that exist now in terms of a failure to respond within particular periods of time to one or more two of evidence-based treatments. And look, it's an important issue that it's not to stigmatize the patient, but I think it is to realistically face that there is this group of people who do treatments that have been very successful and helpful to many people, sometimes are ineffective. And I think it's absolutely critical that we are honest about it, because, I think leaving people with disabling and sort of painful symptoms and without really addressing and developing strategies as to how to better resolve their residual symptoms and disabilities, I think sometimes condemn people to a life, which really is tragically filled with suffering and struggle. So I think there really is a sort of moral obligation of us to be honest about this domain, and to try and develop strategies to better understand it and manage it.
Thank you. Maybe the next in line, and I'll get back to you, Gary, because you're in the same time zone and you don't want to stay up for the whole hour probably. But Rachel, what is treatment resistance? How could it be? Like I heard there's a moral obligation in the last words that Sandy shared with us also. But what's your take, Rachel, on treatment resistance?
Well, Eric, I think you and I have had this conversation before.
We did.
And you know that I don't like the term. I don't think, I understand what Sandy just said, and it's very hard to ever disagree with Sandy because he's usually 100% right about everything. But I don't believe in treatment resistance, because that means that you have more confidence in the treatment than the person. When you apply psychedelic therapies, one of the things you're taught is that you're trying to help the person find their natural healing intelligence, and somebody that sorry for all the noise, and somebody that it's possible that with conventional modalities, people have trouble accessing their inner healer intelligence and moving beyond the trauma. So it's a term that suggests that the treatment is correct, but somehow that the patient hasn't been able to avail themselves of the treatment. And if a treatment doesn't work for somebody, then it's not that the patient is resistant, it's that the treatment didn't help the patient. So I think we want to come up with something better, understanding that we have many approaches. Not everyone's going to respond similarly to different approaches. We talk a lot about window of tolerance in the trauma field. What can you tolerate in terms of trauma-focused work? But again, I think we really have to work together. There's so much brain power on this call to come up with an appropriate term that conveys that a treatment wasn't successful, but that the patient wasn't resistant.
Okay, great. Maybe we can ask that question to Bob. Bob, in your wisdom, is there a better word, or how do you think about treatment resistance?
Yeah, no, that's a great discussion. Thinking of Rachel's comment and also Rakesh's earlier, and with Bessel being on the call, maybe we should ask, what is recovery rather than treatment resistance? Thinking of Rakesh's comment, PTSD is a whole body disorder in Bessel's presence, but it's also a whole context impairment. Now I'm talking specifically about chronic PTSD, just to remind us all, some people get PTSD and recover in 3 or 4 months. All PTSD is not cancer, but some of it is. So when we think about what is recovery, I like to go back to medical models. You know, what do we think about if you think about multiple sclerosis, a chronic waxing and waning disorder? What do we treat? What if you think about a myocardial infarction? The question is, have the symptoms changed? But the symptoms are not the only element to the disease. We could make one of the symptoms go away, and then we'd actually be able to say they don't have PTSD, because you have to have all of them. So maybe we changed the glue, but we didn't change the other 3 symptoms. What about the disability that the person developed? The longer you have a disorder, the longer it enters your life. Once you've fixed a hip, the person still has to learn how to walk, because they've taught themselves a different way to walk to deal with the pain that was present from a broken hip. That's also true with PTSD. Or do we target the trajectory of the disorder? Have we changed it from a chronic disorder to a waxing and waning disorder? That would be progress. It isn't gone away, but we've changed the length of time that a patient experiences the symptoms, the pain, and the impairment. In many ways, our thinking needs to be directed towards problem solving, and that problem solving is a joint activity with the patients who have an illness, not just a disease. A disease we study in pathology. An illness is a disease existing in a person. And when it exists in a person, it has many facets and elements that we need to approach and think about.
Thank you, Bob. And before we go on, I'd like to welcome somebody who's on our screen, and that's not a coincidence, is Miriam Mink-Nedam. And Miriam Mink, she's a colleague at ARC National Psychotrauma Center. Good to see you here with us. Please raise your voice that we know that you're with us.
Thank you so much, Eric, for having me. Yeah.
Miriam and myself and Sandy are currently writing a paper. You can say 2 or 3 words about this, Miriam?
Yeah, well, actually, we thought of PTSD much in the terms that you describe, being not only a psychological disorder, but also a somatic disorder with a range of neurobiological systems that interact over time. So, yeah, we actually try to express these thoughts and yeah, try to define the course of PTSD more in terms of stages, and also the relevance of these stages for the treatment of the disorder. So yeah, we think this is something separate actually from the chronology, that we should see this as a separate category, but that this is important for also the treatment indications that we make as clinicians for the people we see on a daily basis.
We may revisit that later in our call, because we know each other through something, and Joseph Zohar is on the call also, something we call the golden hours of intervention, which is the early phases after exposure to a trauma. It may be different from the chronicity of the disorder, where you've had several quote unquote evidence-based interventions and you're not being able to be cured on a symptom level or on the glue, as Bob Persano said. But let's finish and thank you, Miriam, for saying these words and being with us. Let's go to Rakesh. We've heard some ideas or thoughts on treatment resistance, which we're about to maybe change the word from treatment resistance to another category, or how do you take that?
Yeah, I mean, I mean, again, all of my colleagues, I can't disagree with what anybody said. I think part of it is, though, as a clinician, there's a piece of optimism that you have to bring to your patient, right? So the sickest people I've ever seen, I've always said, after treatment, you will be better. I can't define what better means. It may not mean you're going to be jumping out of airplanes or knocking down doors, but, you know, again, to Bob's point, whether it means, you know, sleeping a little bit better, being able to kick a soccer ball around with your kids. I mean, it's not best cured, whatever. And I think part of the risk, and Eric, you and I have talked about this, the limitations of clinical research, where we do nightmares every day, or we check and PCLs and CAPs and stuff. But I think there's a big difference between somebody that, you know, has a nightmare and says, oh yeah, I'm having a PTSD nightmare, turns over and goes back to sleep, versus somebody that's frightened to go back to sleep and doesn't sleep 4 days in a row. So I think kind of turning it around, I definitely think there is something where some people respond better than others. But I think in terms of how do we define what better means, and I like to still be able to say optimistically that, you know, with treatment, you will be better. I just don't know better versus best. I don't know, you know, where we're going to go. So I think that's the key. I think in depression, for example, you know, two adequate treatments of an antidepressant sometimes defines treatment resistance. But I think you really can't come up with something like that with PTSD, I don't think. So I do think we need to sort of change that paradigm a little bit.
Thanks. Now, Gary, I asked you to stay with us for a little bit. Gary wrote a book on alternative, no, you didn't call it alternative medicine, but complementary medicine, right, in PTSD. Now, how do you take this discussion, or how do you listen into this?
It's such a fascinating thing, and of course, having Bessel van der Kolk on the meeting, I would be very deferential to his expertise in this. But I think it's really important to think outside the box in terms of it in this treatment resistance question, and how do we bring in other approaches and combining other approaches, not just the standard suite of psychotherapies and medications, and even the really interesting stuff on psychedelics, but integrating it into their daily lives. So it is really a recovery process that they engage in over time: exercise, nutrition, that really holistic, whole body, whole mind approach. Because I feel like so many of my patients undermine their own recovery because they're not tending to the basic needs they have. Maybe again, poor diet, or they've stopped exercising, and you know, those are very important in a global recovery. And whether it's treatment resistance or something being undermined by a failure to address another aspect, I think is really important. I want to throw in one other quick comment, just because it's been important to me. I moved to a full-time clinical position these last 6 months on an inpatient service, and work with a lot of people with schizophrenia and bipolar. And what has impressed me after working in the PTSD field for over a decade is how much I see that in my patients. These marginalized and very traumatized individuals, often having exacerbations of their serious mental illness, due to traumatization or re-experiencing of their historical traumas. And addressing that has actually been very effective for me in improving aspects of their life. So I just want to throw that out there. We tend to focus on our specific populations, and I did that for my time in the military. You know, people who've been at war or refugees, people with a very specific trauma, and I understand why. But the integration of that knowledge into how we care for marginalized populations, including the seriously mentally ill, has become really important to me in these past 6 months.
Were the tools that you have been familiarized yourself with in the PTSD domain helpful to address these clinical needs that you're faced with now then?
They are adding things, you know, the prazosin at night for people, talking to my patients who suffer from schizophrenia.
I think New Zealand is now. Okay, Gary.
Focusing on what was a trigger for them in terms of anniversary of a serious traumatic experience has been really important and helped me address some of the exacerbations of the cycles of their illness.
Yeah, thank you for sharing those experiences. If we go now briefly to Masa. Masa is in Japan, and Japan doesn't have a long tradition in PTSD clinical research, but Japan had a disaster, which we all know, the Great Eastern Japan earthquake. And with Masa and others and Leiden University colleagues, we have started to explore by using Masa's data set, 55,000 first aid workers, and looking at their symptom prevalence over the last 10 years, a massive, wonderful undertaking. Masa, if I may ask you, how do you listen into this discussion from a different culture, maybe also in Japan?
So you're asking about the heterogeneity of the PTSD symptom across the cultural background, right?
Yes.
Actually, I do not have a good answer, sorry. But I think the manifestation of PTSD symptom differs according to the cultural background. Especially, for example, in the Eastern countries, people are not willing to disclose the psychological distress. So I think in such a perspective, we should define the PTSD diagnosis standard according to the cultural background.
Yeah. Is disclosure an issue in Japan when you have faced traumatic experiences? Is that something you could relate to on a positive note or a negative note? Is disclosure, talking about it, expressing concerns or distress, is that a difficulty that from your perspective in Japanese culture?
Yes. So recently, PTSD has become very popular in Japan in this 1 or 2 decades. But still, people are not willing to disclose the trauma-related symptoms yet. Yeah.
What needs to happen in order to facilitate that from your perspective in the forces, in maybe the Japanese forces or in the first aid workers that you have worked with?
So I think it's very important to educate all the citizens about the trauma-related disorders. It's very important. I think so.
Thank you. Are you going to stay with us for a little bit, or it's late? We saw Gary, I think, leave because it's very late. If you want to stay with us, we appreciate that. But you may chime in later. But otherwise, thank you for your presence at this late hour, Masa. And I hope that we'll talk soon.
Yeah.
We just published another paper to just do some self and your promotion in the British Journal of Psychiatry. Another paper on. Could you say 2 words about that, or 3, or maybe Masa, because that's also important for us to know what we've been doing together.
I was very impressed. The comment by Professor Urusano, the symptom of PTSD fluctuate in a day or in a week or in a month, and one of our colleagues has published such a fluctuation of PTSD symptoms in the molecular psychiatry recently, and we would like to make a meta-analysis on the symptom fluctuation in PTSD. So if anyone has a good longitudinal PTSD symptom data set, please help us.
Great.
So let's collaborate together.
Your call is notified. Thank you.
Yeah,
Absolutely.
Thank you
All
so
right.
much.
Let's listen to Simon. Simon, how do you hear this on treatment resistance or recovery or the glue or the disclosure? Just your wisdom and reflection on discussion. Any angle you would like to take it?
Gosh, you caught me unawares there, Eric.
Sure. I know I can do that with you.
You always do, Eric. You always do. I'm just waiting for Rakesh to light up his cigar, by the way. I can't bear to see Rakesh going for an hour without a cigar. Funny enough, there was something in the British newspapers this morning about that very subject, in which somebody, I can't remember who it was, but someone quite well known in our world, was saying that they knew of many people who had incompetent treatment from incompetent therapists, but they didn't know people who were themselves, as they say, beyond treatment or with untreatable. They said that patients aren't untreatable. It was Paul Safkowskis, I remember now. Patients aren't untreatable, but they may have doctors who are incapable of treating them, or any health professional, or treatments that are actually don't work, which is a perfectly reasonable view. I think it's slightly rhetorical, because I think we can postulate there are disorders that are in effect untreatable, if only because of unresolvable or unmanageable social situations and so on and so forth. So I think it is quite reasonable, and also I think it's a reasonable concept to have to ensure that we don't get too arrogant or beyond ourselves in thinking that if only the patient cooperated better with us and turned up more and did what we said and took our drugs or went right through to the end of our treatment sessions that we had prescribed them, they would have got better. And given that outside the research sphere where most of us operate, it's not usual for doctors to attempt to, and again, I use doctors because I am a doctor and so are quite a few people on this call, but many others are not. We don't make a habit of following up people who haven't got better. We make a very big habit of discharging from the clinic, but we don't make a habit of going out to find out what has happened to them. We should do, but we don't, and it's unusual outside research that to happen. So I think a bit of humility is in order, but I do think, just as in the rest of medicine, it's not wrong to postulate some disorders that are, at least in the world in which we live, pretty untreatable. And I don't find that completely impossible. But I take Rachel's kind of word of warning on that subject. But I think sometimes that does happen, and I've got patients I've been seeing since I qualified. Not very many these days. The hospital doesn't like me doing that, but I see one or two really just to offer support, and there's nothing wrong in that. Even if the hospital doesn't like it, but there's nothing wrong in that. And usually it's simply because the main circumstance of their lives just remain as dreadful as they always were, and it's well beyond our limited powers to do much about that. you could argue that's a reason for going to politics, and that's actually probably is quite a good reason. But that help for them isn't going to come from professionals like are on this call. That was a bit rambling and incoherent, but it's the best I could do.
But very eloquent, Simon. Also, in the interest of time, because I'd like to enable everybody to raise their voices. But next, Joseph, we worked on the golden hour principles. I alluded to that a minute ago. And treatment resistance in a golden hour perspective is not often used as something that is of a concern. Because just what's your take on treatment resistancy?
So I think the golden hour concept came because we thought how we can avoid reaching the situation when the people are not going to respond very well. And I think in this regard, PTSD is really unique. As was mentioned by Bob, it's event related. So basically, if it's event related, and if we know exactly when it starts, we can do something, or there is at least the potential to do something that could change the trajectory in positive way. So currently, Rachel and I are doing one study about this, but I think looking forward, I would like to see more effort focusing on the golden hours and see what we can do early on in order to prevent the potential of somebody becoming treatment resistant.
Yeah, thanks. Very eloquent, yeah. And the golden hours is an important because of, for instance, what we've been doing in the military and also in terrorist attacks. An index trauma where in the immediate aftermath, you find an intervention that may be of secondary value for the development of PTSD. Thanks. You want to add something?
Yeah, just one more point. I think looking at PTSD and the trajectory of PTSD, we need to look not only on the patient, we need to look on the society, we need to look at the system, and many times the resistance, so-called, is related not just to the patient himself or herself, but to the system, the social implication, and all of this. So basically, I think while we're talking about any disorder, especially or including PTSD, we need to look not only on the patient, not only at the biology, but the society, the norms, and other issues.
Yeah. Thank you, Josie. Maybe I may ask for two people at the same time because they're colleagues at the same university, which is Suzette and Andy from University of Alberta in Canada. How do you listen into this recovery, treatment resistance? Would you chime in with some comments or observations from your end?
Eric, I think I'm going to ask Suzette to go first, but I'll tell you a little story about PTSD in academia. We engage in this repetitive behavior of rushing towards grants at great haste. And yesterday you received an email from the Canadian Institute of Health Research that indicated we got our grant in at 1759, when the deadline was in fact 1800. And so we were having a debrief afterwards about the hypothalamo-pituitary adrenal axis and should we really be doing this? But it really is a good cause for celebration afterwards and decompression. So Suzette, over to you for a comment, and then I'll chip in.
Thanks for that, Andy, and Eric for the opportunity. I just wanted to circle back to what Rachel mentioned in terms of the agency of individuals, and also what Joseph just said in terms of a socioecological perspective. So I just want to touch on those two things in terms of the agency of people to be able to find meaning and purpose in their life and to have a sense of control over envisioning forward for their recovery. And if we don't have that sense of engagement as clinicians, that the possibility of recovery is really limited. So I think we can offer many things to different people and find all of the appropriate tools and interventions. But if the individual isn't able to engage in them and or for whatever reason those don't work so well, it's I think it's more problematic. I think sometimes we from a engaging with the individual perspective, taking a holistic perspective along that recovery trajectory is really important, knowing that different people are going to respond to different things and have different resources that they may or may not tell us about. I think, Eric, some of the incredible work that you've done and others on this call around looking into moral injury, for example, or the other domains, the physical domain, the intellectual domain, lots into the neurobiology, but into this depth of who people are, a sense of meaning, purpose, what animates them, and the other aspects that may need to be explored from a really holistic perspective. I think of the work that you brought forward around forgiveness, for example, and the need to look at the relational dimensions and Rachel, I reflect on some of the comments that I've heard you speak in terms of the importance of community and looking out beyond the person into the social connection. So I think that there's a basket of services and a basket of different kinds of interventions that we need to approach on an individual level to animate and engage with people to find out what animates, what's going to work for them, what aligns with their values, with what trajectories are going to be helpful for them to help them in their course of recovery, wherever they are. And then there may be some points in the recovery, as all of us have seen, where someone may need a boost of something. And so maybe there's a basket of services that really is person-centered, person-led. And to Rakesh's point, that little bit better is a best for that individual at that particular time. So I think a basket of services, a trajectory of services that are really led by personalized medicine, which we've heard here as well, to really listen to the person and to engage them in their course of recovery, and their families and the social system. To Joseph's point, I think we can, as we all know, see people who are recovering, but put them back into that same environment or into a situation where many of us, all of us, would be potentially at high risk for trauma and whatever that looks like. So any one of us would need that intervention in the golden hour. So I think forgiveness, the deeper domains, the meaning and purpose, getting a sense of reconnection with one another and with ourselves, for our clients, with both the horizontal relationships as well as for many who have a vertical relationship with someone beyond themselves, that we really need to take into consideration that deeper dimension for some individuals. So a holistic perspective, and that's biological, sociological as well. And I think that you've really contributed to opening up that level of looking at the neurological, the biological, the holistic, the whole body, as well as those deeper invisible, I really love the analogy of you making the invisible visible and pointing in a direction for us to be able to look there as well, within the person as well as between people.
Well, it was David Spiegel who mentioned visible, making the invisible visible. And maybe if I connect to you now at this moment, any reflections on this discussion from your end? May I call out to you?
Were you asking me, Eric?
Yeah, please.
Oh, thank you.
Yeah.
Well, first of all, you are showing us so well now what you've done throughout your career, which is make wonderful connections among colleagues and contribute to both the database scientific exploration of trauma and PTSD, but to the human side of it and what it means. And I think we're facing something that's, bigger than all of us. And what our patients go through is also a reflection of what our societies are going through. And they often pay a higher price than others for guided or misguided efforts that go on in the bigger picture. And therefore, the social dimension that was mentioned recently is terribly important, because part of the problem, I think one reason that MDMA is looking promising in treating PTSD is that people feel so cut off from ordinary human discourse by the experiences they've undergone, and ways of helping reconnect them to their social world, in addition to working through the and desensitizing elements of the trauma, are very important, and helping them also discover internally aspects of themselves that surprise them, sometimes negatively, sometimes positively, I think are very important parts of what we do. But so the social exercise you're engaging in so expertly right now, Eric, is exactly what you do so well and what the field needs. So I thank you for doing that.
Thank you. That is sort of implicit in the discussion on the overt level, and on the covert level, it is what we're doing. We're connecting, and that's really important that we underscore that. That is what brings this field together, really, with these brains that are listening to each other, have a conversation about these things. Thank you, David. With the notion that we have about 6-7 minutes or so, and I know with the danger that if I give the word to Rick, he's gonna eat it all up. So not yet, but let's hear from, but I'd like to give you the word, Rick, for sure, absolutely. But Torsten Passi been in this universe, not specifically in PTSD domain, but in a domain that we call the psychedelic medicine domain. And are the psychedelics the way out to go out of the treatment resistancy or so? Or maybe I'm jumping into that conclusion too quickly, but what are your thoughts, Torsten? But be respectful that we have Uli that'd like to listen into, and of course, Guga and Irina, and not to forget Andy and Rick, of course. So please be brief, but reach out.
Okay, I'll try to be very short. So it's a very important topic to my eyes. Thanks for choosing it. And the problem to my eyes is that there is no universal definition of treatment resistant. There is no scientific definition of treatment resistant, and it may be tempting for a lot of therapists, as I've seen in the past, that they say, oh, he is treatment resistant. And I had, even as a student, I had to raise my finger and say, they are treatment resistant in respect to your method that you use, not more. You can't say more than this. You know, and what I also think is a problem with that, it looks a little bit like a categorical thing instead of a spectrum, which means, you know, you're treatment resistant or not, but you're partially treatment resistant maybe. And let me just mention another point, which is you can have a causal kind of treatment with a lot of people which have had MDMA. So the cause, so to say, the neurobiological cause is gone afterwards, but you also can have treatment with a symptom reduction, as with heroin, for example. A lot of PTSD symptoms can be diminished by taking heroin, and therefore my plaidoyer would be for another term: difficult to treat PTSD. That could be a kind of.
Okay, just a quick follow-up question. You've worked with Leuner, who was sort of a similar person to the Jan Bastiaans in the Netherlands, was Leuner for Germany, perhaps. And Leuner was also using psychedelic compounds. Is that a sort of, I wouldn't say a way out, but is it a way forward for us in this discussion that we currently have?
Yeah, in a way it is, but as usual with all new treatments, at first they have very high odds ratios, or effect sizes, which go down somewhat, but it seems that MDMA is very stable. And I see, as a person who has really worked with these substances over tens of years, I see mainly MDMA as a treatment which is really impactful for PTSD treatment, not so much LSD, psilocybin, and so on. But as you know, as PTSD researchers, if a significant traumatic event has impacted someone's life, it may alter his way of developing as a person. And then, you know, all that this has been conceptualized, thankfully, as a development trauma disorder. so that some, you can't get hold of a trauma or just one traumatic event. You have to treat all the stuff which has been an outgrowth of that.
Thank you. Now the connection is easily done. Rick, thanks for staying with us after an MRI procedure in Boston, in Massachusetts. We look forward to your reflection on this discussion, not specifically on treatment resistancy, but maybe your reflections on listening into these colleagues in our domain.
Yes, Eric, it's just a pleasure to share this time with you and with everybody else. I think treatment refractory might be a better thing. It doesn't really blame the patient. Treatment resistant puts it on the patient. But we have now enrolled 77 of the 100 people in our second phase 3 study. And we should have the results, the interim analysis in May, and then the final study will be done in October. And we're hoping for, if it goes well, approval in the US before the end of 2023 and in Europe a year or so later. And I think it's interesting also to think about group therapy. We haven't really talked about that much, which is we really need to explore that. And then also we need to really think about cultures around the world where there's large amounts of trauma, but not enough psychotherapists or psychologists. How do we have other models with indigenous healers, different group sessions, somehow to bring it to where all the trauma is? And that's what we're going to be also looking at in the years to come. And then also there is a small project with Israelis and Palestinians using ayahuasca and MDMA together. So beyond this sort of cultural trauma, where we talked about cultural factors, there may be ways to help people get beyond their fears of the other. And it could be that we'll develop treatments that would have combinations where you might get MDMA at one point and then psilocybin or LSD at another point, even sometimes LSD and MDMA at the same time. So there's just an enormous amount to explore. Mm-hmm. And we're very excited to be moving forward with all the wisdom here at the people, and also with your leadership and participation, Eric.
We need to underscore, and I want to take this opportunity also to hear you say, or I may start first, is it's not the MDMA that does the trick, it's the catalyst for the therapy that unfolds afterwards, right? We need to sell that message every time on and on, right?
Yeah, I think so, because people can have an MDMA experience and their trauma can come up, and if it's not a supportive setting, they can end up worse off. So it's definitely the therapy that the drug assists rather than the drug is the main thing.
Thank you. Uli, and then we go to Irina and then Guga, or in another fashion. And then we're sort of at the close of the hour. If I hope that I haven't forgotten anybody else. Andy, did you wanted to add something to Suzette, or?
Yeah, I just had one very brief comment. I went right back to Rachel's answer in the beginning about expanding that into all the things that have been discussed. Two things come up for me. One is accessibility and the other is cultural appropriateness. So we can have all the research questions answered and we can have things done in a very controlled environment. But for that to have value out into the concept of what is treatment non-responsive or treatment refractory, that really comes down to the individual patient and the resources. And Rakesh made the comment that if you're ex-military or serving military, you have great access. But if you're out there and just an individual in a variety of this places in this global arena, it can be really difficult. So is that really meaningful? And it comes down to the individual and personalized medicine, precision health, however you want to say. But there's a big gap between research and the practice environment in which things can be accessed. But it's hopeful with the information. It's been a great conversation. Thanks for including me.
Thank you, Andy. Uli, listen into, and then Guga and Irina. And then I thank you for your time. But let's listen to Uli first, who was at the Max Planck for many, many years and is now at the University of Bonn. Uli. We just did an RDoc analysis on these new leads for PTSD, right?
Yeah, right. We worked on RDoc, and I take this moment to thank you for all the good years of collaboration, and I hope it will carry on in the future. So this is a retirement symposium, so to say, but I think it's also a new starting point maybe, or a point for continuing for you and for us, all of us, to collaborate. Regarding the topic we are just discussing, I think it's regarding treatment resistant patients. I don't like the word either, I agree with Rachel, but I think it's important to combine therapeutic methods we already have. So pharmacological and psychotherapeutic methods, and MDMA is a good example. The combination with trauma exposure-based psychotherapy, I think it's one of the important ways for the future. And I think it's, we should also keep in mind that we further engage in enlightening the neurobiological mechanisms underlying all these effects. I think this is very important to fight, however you call it, treatment resistant or treatment refractoriness. I don't know the English subject for this. Yeah, thank you.
Thanks, Uli. And we'd like to sort of close with two countries that are under a lot of uncertainty these days, Georgia and Ukraine. More Ukraine probably currently than Georgia, but both have been under situations of threat. And when I visited Tbilisi, Guga, how do you listen into this from the Georgian perspective? You've been in the Georgian armed forces, and Georgian armed forces have been very helpful in Afghanistan, and they were close to the Dutch. Just a few words from your end, Guga.
I would like to say about resistance treatment that I think that the comorbid disorder is very important, which cause mainly the resistance, especially for maybe OCD, GAD, panic disorders. You remember that we made some research about this comorbid disorder and some mediation analysis about this topic. And I think that when we are planning the treatment method, psychotherapy, or using some medication, it's very important to take into consideration the comorbid disorder. Especially, I think the OCD is mostly influence on treatment resistance or PTSD.
Thank you, and that's what you're doing your PhD on, partly. Yeah, thank you. All right, and then lastly, Irina, we hope that you're going to be safe in Kiev, and we hear all about the news and the tensions that are there. You may relate to what's going on there, but you also may relate to discussion. What do you want to contribute at this moment? Either way.
Thank you. I just want to highlight two things that already was we heard here. First is that in low-income countries, the access to effective treatment is very low, or even no access because of lack of resources. And I think it's worth to invest into development of digital tools of prevention of PTSD, because it's the number of people affected with natural disasters, terror attacks, or warfare, or other traumatic events can be like tens, or can be thousands, or even millions. Like in Ukraine, we have more than 2 million people internally displaced. And currently, the current situation, of course, it triggers the trauma of those people who were fleeing war 5 or 4 years ago. Now, all of them experiencing this re-experiencing the traumatic event. So, digital tools in prevention of PTSD should be in our agenda as well. Thank you.
Thank you, Irina. And Irina is the chair of the Traumatic Stress Network of the ECNP, and working on the app that we're working on together, the first Aid to Terror with Joseph Zohar. So we'll hope to hear from that soon as well, Irina, and hope you're going to be safe there.
Thank you.
Hey, this is, I see on my screen that I hope to have enabled you all to participate in this from wherever you are in the world, from the east to the west. This has been a true delight. It's been a technological challenge for me to whether it would work. And the moment that I called out for the technicians, whether you're all there, you all popped up, which was like, whoa, this is truly, as David said, this is amazing. It is really, that we can do this together, that we can reach out to each other, not leaving a footprint, but we listen, and I feel that this brain power, as I think Rachel said it or somebody else, is enormously valuable for this field. And we could do a NATO advanced research workshop on this, meeting each other in Odessa or in other locations of the world, hanging out, having a cigar, Simon, with Rakesh, who knows? But I look forward to the event that we can toast on my farewell and the future that lies ahead of us. And we have a sort of a moral opportunity for all these guys that have served in the forces and have been exposed. And this has been a very fruitful discussion. And here in the audience, there's people that have been very silent, very listening into this. So I hope that they had also the appetite that I felt listening into you. So unless you wanted to say last call, but it's been a little bit after 5. We'll open up the reception for a few drinks here. I hope that you have an opportunity to drink on my retirement. And I really, truly appreciate the time that you spent with us here today, this morning, this afternoon, today. And I look forward to seeing you all again soon. Take care. Thank you. Thank you, Bob. Thank you, Rachel. Thank you, Rakesh. Masa, arigato. Simon, thank you. Josie, thank you so much. And Suzette, we'll do a thematic analysis of all this, right? When we do the transcription. Thank you. Good
Absolutely.
seeing you, David. Wonderful. And Andy, sleep well now after the grant submission. And Rick, all the well with the procedure and the healing afterwards. Great to see you and that you were with us. Torsten also, same. And Uli, we'll talk soon. And Guga, all the best. And Bessel left us, I think, a little bit early. I didn't want to leave him out, but I didn't see him. And Gary, oh, he's there still with us. Gary, sleep well. All right, in Wellington. All right, take care all. Bye-bye now. Zo, nou, ik denk dat het is 5:10 en dat het wel tijd is om even de benen te strekken. Ja, ik geniet hiervan, dat steek ik niet onder stoel op. Ik hoop dat u ook hebt genoten van de manier. Dit is hoe we onderzoek kunnen doen, hoe we met elkaar in verbinding kunnen zijn en waar we kunnen leren van elkaar. Een open dialoog, ik zal niet meer over zeggen. We gaan gerust even hapje, drankje. Eén ding wat ik nog even wil zeggen, Leo herinnert me aan, daar staat de uitgever van Fred Ladenois en die heeft op zijn tafel de boeken die hier gepresenteerd zijn staan. Die boeken die kosten normaal ergens in de 32,50 en hier mogen ze worden aangeboden voor €20. En Leo is er om te signeren, dus als ik wil 1 of 2 of 3 boeken mee naar huis nemen, dat kan allemaal. Als u eerder weggaat, dan misschien de gelegenheid is om mij nog even gedag te zeggen en u moet weg. Er ligt nog een boek voor allemaal, dat kost niet niks. En dat is het boek over het leven van iemand die onlangs overleden is, de major Robert Niepels. De major Robert Niepels heeft het Niepels-Stans PTSS-fonds opgericht, heeft een grote donatie aan het LUF geschonken, wat ik heb mogen benutten, waar veel van de activiteiten die ik heb kunnen doen uitgeput zijn geworden. Dat boekje is het leven van Robert Niepels, de generaal-major Robert Niepels. Een zeer, zeer bescheiden man. En als u dat boekje leest, een prachtige man. Helaas, hij heeft COVID lang kunnen doorstaan. Hij had ernstig karen. Dat boekje krijgt u sowieso mee naar huis. Dus daar ligt het op een stapel. Leo heeft het geschreven, want het is biografie van Leo. Als u zegt, wilt even Leo laten ondertekenen. Leo, ik denk dat jij bereid bent om dat te doen. Dus we zien elkaar bij de receptie. Dank in ieder geval voor uw aanwezigheid. En nog één opmerking. Eén opmerking van Leo.
Iedereen die nu een boek koopt, de €20, het geld gaat naar het Niepels-Stans-fonds. Wat vandaag verkocht wordt, gaat allemaal naar het Niepels-Stans-fonds. Dus niet naar de uitgever, niet naar mij, niet naar Erik, maar naar een goed doel.
En als u nou mij mijn dankwoord wil horen spreken, want ik heb iets van een dankwoord, daar kom ik straks.